talk about thyroid carcinoma, which is a scenario which is extremely important from a pediatric endocrine perspective. I largely touch base about how to approach thyroid nodule in particular, because therein lies the importance of identifying it at the right time. And then how do we manage from that perspective? So this will be the way we'll go forward. So approach clearly here would be based upon initially TSH. If your TSH is less than 0.1, thyroid scan should be done. And if you have an increased uptake, you should go ahead with a surgical intervention because it's a toxic nodule. If you have a cold or an unclear lesion which is there, you should go ahead with a fine needle aspiration. While if you have a lesion above TSH is more than 1 and your size is more than 2 with spongiform 1.2 to 2, with mild lesions 1 to 1.5 is suspicious lesions 0.5 to 1. So invasive lesion, which we discussed in the table, you should go ahead with a FNA in that regards. Now, if your FNA is non-diagnostic, do a repeat or surgery. If it's benign, follow up after a year, and if size increases by more than 20% or volume by 50%, go ahead with a surgical intervention or a FNA. Atypical lesion or a follicular lesion, do a molecular study / repeat / surgery, which we discussed in much more detail. If you are suspicious of malignant lesion, you should go ahead with surgery in this regards. So we'll start off with a few cases just to highlight these scenarios. 8-year-old boy with thyroidal swelling, we can see, which is there in the midline. It was there since birth. It is mobile. There is a slight tenderness which is there, and it moves with tongue movement. So I think this is a very, very important clue. If you have a thyroid swelling, which is midline, ask the child to swallow, ask the child to bring the tongue forward, and you will identify that this is an important lesion. There's a thyroglossal cyst. The best way to identify is a thyroid scan, and surgery is recommended in this regards because they have a high risk of malignancy in this perspective. A 14-year-old girl with thyroid swelling, and what we are looking at, this is a big swelling, 3 to 3 centimeters. So again, you're worried about that. It's mobile. You see the big swelling which is there. There's also other features which are there like weight loss and tremor. So as I said, the first thing to look at is functionality, because that really saves you the risk of malignancy a lot. So you need to look at the TSH, which is low. So if your TSH is low, you're looking at a toxic nodule. And what you're seeing here is that you have a hot nodule. All the other areas are suppressed. This is clearly a very low risk of malignancy. You don't need to do FNAC. Go ahead with surgery. Do not give radioactive iodine because this could have a risk of thyroid cancer subsequently. 17-year-old boy with thyroid nodule. Again, it's a big size, 1.2 to 1.5 centimeters, a firmish nodule. There's also tremor and palpitation. So again, there are features of thyrotoxicosis. You have a high FT4 and TSH is low. So again, an important scenario to look at. Scan shows increased uptake, but the remaining area is not suppressed. So this is different from what we discussed in the previous case. So what do you think should be done? Maybe you can put your options in the chat. You can put what you want to do. So this is different from the previous case. The previous case, the nodule was increased. The remaining area was completely suppressed. Here, the nodule shows an increased uptake, but the remaining area is not suppressed. So what should be done? I hope some of you would have agreed that this scenario requires an FNAC because this is a warm nodule. There is a risk of malignancy, and you can have a papillary carcinoma in this scenario. Another interesting scenario, 16-year-old boy, follow-up case of Hodgkin's disease, cervical radiation was given. He has a slightly high TSH. Now, this scenario I alluded to is a very, very important thing to remember. TSH is a potent stimulus of thyroid growth. So if you have a high TSH in somebody who is predisposed to a thyroid malignancy, you are actually playing with fire. You don't want to wait here. You have to clearly do something to suppress this TSH down. This is one indication of subclinical hypothyroidism where I'll definitely recommend immediate therapy to avoid any long-term risk. Even though the TPO may be negative, don't do this. Do not ask them to follow up. On follow-up, you may develop a nodule and risk factor. So this is very, very important that in somebody who has a high risk of malignancy, do not allow the TSH to go up because this is something which can further increase the risk. 14-year-old boy with thyroid nodule, which is recent onset, rapid progressive. Again, a red herring, as we have discussed, it's 1 centimeter, not very big, but solid cystic area is there. So I'm a bit worried about that. FNAC is non-diagnostic. So just because you have a non-diagnostic FNAC does not mean that you don't have a malignancy risk. you need to be worried about in this scenario. You may have a rapid increase and papillary carcinoma may develop. So you need to be very cautious in a non-diagnostic scenario. 15-year-old girl, and if you tell them that, okay, come back after 2 years, most of them will not be coming. So ask them to come after 3 months, 6 months, and then maybe you can be a bit more liberal in that regards. 15-year-old girl with thyroid nodule, which is mobile, there is no lymph node, TSH is normal. There's no history of radiation or familial scenario. Ultrasound shows 0.8 to 0.7 centimeters with no suspicious features. So what should we do in this regards? Clearly, we should ask them to follow up and see if the size increases by more than 20%, volume more than 50%, then you go ahead with FA.